Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Tony Varela. I am a physical therapy clinician and educator and an interviewer for AOMP podcasts. Today I have the privilege of talking with Dr. Damian Keter. Dr. Keter is a clinician and educator at the Cleland, U.S. Department of Veteran Affairs Medical Center. He serves as a clinician, clinical researcher, and mentor for the Physical Therapy Orthopedic Residency Program and a National Pain Mentoring Program. He earned his DPT from Chatham University in 2013 and his PhD from Youngstown State University in 2023. His dissertation contributed to the manuscript we will discuss today, Priorities in Updating Training Paradigms in Orthopedic Manual Therapy, an international Delphi study. Additionally, he has multiple publications that discuss the evolution of manual therapy, education, and delivery with a person-centered approach. Our conversation today will also touch on his recent manuscript entitled Integrating Person-Centered Concepts in Modern Manual Therapy. Recently, the AOMP Research Committee awarded Dr. Keter the inaugural AOMP Emerging Researcher Award for his contributions to research in orthopedic manual physical therapy. The views expressed in this podcast are those of Dr. Keter and do not necessarily reflect the position or policy of the Department of Veteran Affairs or the United States government. Well, welcome, Damian, to the show. I'm looking forward to this conversation.
Thank you, Tony. It's an absolute honor to be here with you today. So thank you for this opportunity.
Well, you have a couple great papers out that I'd like to discuss. And I'd like to begin by telling you a little story that speaks to your papers. I gave a lecture on biopsychosocial approaches to a state conference, and something told me to start the lecture by saying to the group, I admitted that I am a certified manual therapist, which got a really good laugh, by the way. But I thought it was a really important point to make that the foundations I was building my psychosocial approaches were based in manual therapy and my interactions with the patients. And at the time, I recognized that there are a group of people who are now against manual therapy because of the passive nature of that approach, but also believe that it needed to be incorporated and evolve with the times and the approaches that we were taking with our patients. So I came across your papers. Of course, Chad Cook, who I interviewed a couple weeks back, turned me on to your papers, and I thought it was just appropriate for me to talk with you and for a discussion on how the concepts of orthopedic manual physical therapy are evolving. And it seems like you are spearheading that process. With all that being said, we'll talk about your two papers, the main one being your Delphi study entitled Priorities in Updating Training Paradigms in Orthopedic Manual Therapy, an international Delphi study. Can you take a moment and explain what inspired you to do this study? And if you could also explain what a Delphi study is to the listeners.
Yeah, absolutely. Thank you, Tony. I think your example that you just provided is the exact reason why I thought it was appropriate to dive into this area of research. And, I did my dissertation in this area, and there's kind of this misconception as this biopsychosocial model surrounding pain came about, people forget about the biological aspect of it. And people really focused on the psychosocial and said, well, if there's anything that isn't a psychosocial treatment, it kind of gets put on the back burner. And unfortunately, manual therapy was one of those. And manual therapy being viewed at overall as through a very biomechanical lens by a lot of folks that don't understand what we're doing, it got put as this, well, can we still include this, or should this still be included? And so unfortunately, it put kind of a bad lens on manual therapy. Now, me being a clinician, I saw the value in manual therapy and hands-on interventions, and we don't even have to dive into the amount of literature that supports its value. And I think you mentioned manual therapy as a passive thing, and I don't think it necessarily is. And I think Jason Silvernail did really well outlining in his definitions paper in Physical Therapy Journal the fact that it's not a passive thing like some of these hot packs, cold packs. And then a recent publication that really interests me, John Mayer led, just published ahead of print in PT Journal, also split manual therapy away from passive modalities therapies. And so what they did is they looked at active, passive, and then manual therapy separately and found that manual therapy incorporating with active treatment actually reduced downstream opioid utilization. And so, this just adds to the plethora of information that we have showing that manual therapy is effective. It works, it has a benefit, it's a good tool to have in our toolbox. The challenge is, how do you take this thing that we know has value and adapt it to align with these newer models per se, such as the biopsychosocial model, so that they mesh together? And I think me coming from a background where I had done a lot of the pain science and pain neuroscience training, and I help educate in some of the VA programs on pain education and whatnot, as well as understanding the value of manual therapy, and along with my manual therapy training, these things work really well together. The challenge is, okay, we need to put these things out there so that people understand how these two worlds align. And that's where my interest for my dissertation topic and this Delphi study, along with my others, kind of comes about. It's kind of that marriage of the pain science world and manual therapy world to make people realize these aren't enemies. They work on the same front. It's just a tool in your toolbox that's able to help manage these complexities of pain. With that being said, a Delphi study looks to obtain consensus on something. So in this case, we said, okay, we know that manual therapy training largely in the past has focused on very biomechanical constructs. We know that a lot of the literature doesn't support that that's the main reason that it might work. There's some great research that came out by Casper Nim and his colleagues looking at this lack of specificity in some of the manual therapy techniques. There's a lot of research coming out on this whole concept of the mechanisms behind manual therapy, which I hope we get to talk about a little bit more today. I think that's really the future of where manual therapy is going. And then we know overall there's all these contextual factors that influence not only the response to manual therapy, but also the pain experience itself. So in light of all of this information, it's okay, how do we update how manual therapy is taught in advanced manual therapy fellowship programs to pull it away from that biomechanical lens, to make people see it through a different lens? So the idea with this is a Delphi study. It's what's considered a mixed method study. So it has a qualitative component as well as a quantitative component, which looks to gain consensus on a topic. So for this study, what we did is there was 3 questions which we posed to the group of content experts. The first being, what should we focus on in advanced manual therapy education? The second was, what should we omit focus on in advanced manual therapy education? And third is, what is the foundational knowledge which is necessary to apply manual therapy? And like I said, these Delphi studies are consensus measures where the first round present a questionnaire to these people who we identified as the experts for this study. And we provided them with these 3 questions in open-ended format. And so we basically said, here's the question, what do you think? And some of these individuals gave us bullet point answers for each of these. Some of these individuals write a nice paragraph for each of these. But the idea with this is then the authors of this paper went through and we used an idea called literal thematic coding to go through and pick out all of the individual themes which we saw within all of these open-ended responses. We then take in round 2, we put these same themes back with these same questions and had the same individuals rank these on a Likert scale. So basically assessing their agreement with or disagreement with these. And then we summarize these responses and we present the same exact questions with the same Likert scale along with the responses from round 2 back to the individuals so that they're able to rank these again, now seeing what other individuals had ranked on these things. And so it's kind of a nice way to unblind everyone else's responses to the group so they're able to see these things. Everything that gets 75% agreement is going to be something that reaches consensus, that this is something that should be included, omitted, or a foundational component of orthopedic manual physical therapy training. And so these Delphi studies are really useful in medical education, really useful to guide agreement on where there's gaps or where things need to move in the future. But the overall idea with this is it's things that are already out there. It's not creating a theoretical framework. It's saying these are what people that are considered content experts in this field think should be focused on. We came up with some really interesting results.
Thank you for that explanation. Going back to the people that you invited to participate in the first round, can you speak to how you chose them and their credentials across the board?
Absolutely. And Tony, that's a great question because in consensus research, the consensus is only as valuable as the experts that made it, right? So if I find people that have no expertise in an area and say, what do you think? That might be consensus amongst that group, but they're not experts in that field. So what we did is we really wanted to make sure this represented people that truly understood advanced postgraduate manual therapy education. And so what we did is we utilized the IFOMP database, the International Federation of Orthopedic Manual Physical Therapy database, and their associated national databases that they linked to individually search all of the programs for any individuals who were identified as educators within those programs. Now, we wanted individuals who were justified content experts. So we said we wanted individuals who were fellowship trained, as well as those individuals who may not have completed a fellowship but had completed a terminal doctorate, so a DSc, a PhD, something along those lines, with significant research in that area of expertise. So those individuals who maybe teach in the fellowship programs, have done a PhD looking at concepts in there, but never completed the fellowships themselves, they were still included as well. With that, we identified 164 individuals across these different databases. We ended up getting 41 respondents across 4 countries, 35 of them being fellows and 20 of them having terminal doctorate degrees. So as you can see, most of them were still fellowship trained. Unfortunately, when we got the responses and we found our kind of potential list of candidates for this, most of them were located in the United States. Unfortunately, a lot of the web pages in the US linked to, hey, here's all of our instructors, individual emails for them. So it was really easy to pull those out of there. Whereas some of the other countries and whatnot, it was harder to find individuals to participate. So it was heavily weighted in the United States related to our respondents.
In the original 164 that you reached out to, were any of them also osteopaths?
There's a lot of variability in different countries related to some of these different roles. And osteopathy is definitely one of those. And I think, Laurie Hartman did a beautiful talk at AMP a couple years back where he touched on this a bit, this idea that a lot of the, osteopathic profession has moved more towards medicine and away from some of the hands-on techniques. And I think different schools of thought, osteopathy as well as chiropractic, have also published similar papers to this, not necessarily consensus papers, but papers to this that have also called for a change to update their training paradigms, to update their application of things. I know George Estevez did a beautiful paper. I think it was the International Journal of Osteopathic Medicine in 2020, looking at this idea of updating the framework of osteopathic care. So there's been a lot of talk around the fact that they need to update how these things are incorporated, because that truly is how you differentiate, right? Osteopathy versus medicine. But no, in our study, we only included physical therapy.
Yeah, thanks for expanding on that too, because I think it's important to understand that there's a lot of different lines of thought along the way. And most people understand that based on their training and the different expertise or experts that they are training under. With that being said, what were the major themes that came up with consensus for inclusion and the major themes that came up with a consensus for omission? And I know that there was a lot.
I think overall, the thing that was most interesting to me outside of the individual themes, which we'll talk about in a moment here, is the overall trend here. It was include everything and omit almost nothing. And so basically the consensus was every single theme that was presented as a potential area to focus on, all 25 of them, they said all of these things should be included. All the consensus was met on all of these things, more than 75% agreement, all these things should be included. Out of these 19 themes that were presented to exclude, only one of these met consensus to actually exclude. So I think this in itself really speaks to the breadth of information that these individuals feel is important for advanced manual therapy education. And I think it's really important for us to understand why these programs involve as many hours as they do and why they take as long as they do, why this is so much different than going to a weekend manual therapy CEU, right? You see this and you say, wow, this is a lot of stuff that we're expecting these individuals to master through completion of a fellowship program. And so I think that in itself spoke a lot. The trends we saw, person-centered factors, looking at things like patient comfort, patient handling, communication, managing patients' expectations, all ranked very highly. Also, things like safety and ability to modify the technique during the technique ranked very highly. The technique-specific factors met consensus, but they actually didn't rank as highly. So we did what's called a composite score to see how many people ranked things as strongly agree versus just agree, and basically what the strength of the recommendation was. And what we found is technique-specific factors. So things like ability to grade mobilization, localizing a tissue dysfunction, use of OMT for soft tissue dysfunction, things like that, didn't have as much support as some of those other patient factors which we saw, which really kind of supports this whole concept of what we talked about, this idea that transition is away from this specific tissue pathology and really leaning towards this person-centered care or looking at this person as a whole. Another thing that was really interesting when we looked at the results of this is there was 3 different mechanistic type of things which were presented. Okay, one of them looking at, okay, we need to teach them the psychological mechanisms associated with OMT. One of them was we need to teach them the biomechanical mechanisms associated with OMT. And one of these was looking at the neurophysiological mechanisms associated with OMT. The interesting finding here is while all 3 of these met consensus, there was significantly higher support for the neurophysiological mechanisms and the psychological mechanisms than there were for the biomechanical mechanisms. And so again, they all met consensus. They're feeling that all these are important to include, which I agree with. But there was this idea that we really need to leverage the fact that there's other stuff, there's other mechanisms going on which are contributing to how the patient responds. It's not just this biomechanical thing of I'm closing this joint. There's a lot more to it than that. And so, as far as the inclusion stuff, those are the things that were really, really interesting to me. The exclusion question related to what we should omit from manual therapy training, only one of the 19 themes presented met consensus, and that was visceral manipulation. Okay, that was consensus met that should be omitted from focus on manual therapy training. Now, I have to disclose here, I've never taken a manual therapy course looking at visceral manipulation. I do not do visceral manipulation. I know nothing about visceral manipulation, right? And this paper isn't based on my own opinion because I've had a couple individuals reach out to me and say, oh, well, it worked. That's fine. And this paper just summarizes what these individuals felt about it. And this was the one theme that met consensus on being omitted from manual therapy education. So that was the only one that met consensus. There was a few other concepts that were near consensus, looking at complex reasoning that is not observable or reproducible. So this idea of, yeah, I'm changing this tissue, but you can't see it. There's no effect of it. There's no change associated with it. That was near consensus as one of the things to admit. Looking at non-reliable assessment techniques, things like SI joint anominate and some of these things that have been questioned a lot related to their reliability, that nearly met consensus as well. So it was between that 60 to 75%, but didn't quite hit that 75% threshold. And then looking at things like treatment fads and treatment based purely off a research driven model. And I think this was a really interesting finding to me as well. There was near consensus that you should not focus on manual therapy education just looking at research driven models. And I think that this is an important thing when you look at person centered care. Right? We look at, okay, we want to focus on the patient in front of us. And this is saying we should not be just honing in on the evidence, the research itself, and saying this is the only thing that matters. There's more to it than that. And so I think that was a really interesting finding there as well. There was a couple areas which were really interesting, and there was a bit of a conflict. One of these was related to pain science. Pain science actually came up as one of the things to include, and it met consensus. It also was proposed as one of the things to omit. And so it was one of those things that showed up on both lists, is it's something you should focus on and include, as well as it's something you should omit, but it did not meet consensus in the omission group. Another thing is that when we looked at the responses to the biomechanical principles, when looking at the biomechanical mechanism, people felt very strongly one way or another. It was more of this strongly agree and strongly disagree than the people who felt more moderate with the agree and disagree. So people felt more strongly toward you have to include this biomechanical stuff, or you have to exclude this biomechanical stuff, or vice versa. So that was another very interesting finding based on the results that we saw.
There's a lot to unpack in everything that you just said. Let me start by seeing if I can safely interpret something that you said. You said that almost all the major topics or concepts in manual therapy, there was a consensus for it to be included.
Yes.
So would it be safe for me to think that the evolution of orthopedic manual physical therapy is more about reframing the concepts that revolve around it as opposed to changing the actual substance of manual therapy itself?
If you're talking about comparing it to the way manual therapy was framed, 10, 15, 20 years ago, I don't know if you would have gotten these same responses to the round one questioning, which was the open-ended questioning, right? Like the concepts of patient-centered care, patient-centered communication, therapeutic alliance, managing patient expectations. I don't know that if we would have done this study 15, 20 years ago, that you would have had those same topics that would have came to light. And so I think that based on the fact these content experts provided these themes in round one, I'm not sure how it relates to changing what was there 10, 15 years ago. And to be honest, we know it depends a lot on how you were trained, right? I think that when you look at this and when we understand the differences between philosophies, I would guess right now there's individuals listening to this that say, well, yeah, this makes sense. This is all how it was taught. And there's probably other individuals listening to this right now that say, well, no, this doesn't make sense. This isn't how I was taught. This isn't how my fellowship program taught these things, right? Because we know depending on your school of thought, how you were trained, who you went through is going to ultimately influence how you feel about this stuff as well.
Yeah, that's interesting you would say that because I was taught from a very biomechanical point of view. And to me, it was important to understand that as the foundational evidence on why I was doing what I was doing. However, I intuitively understood that there was a psychosocial component to it. The second question to unpack everything you had said was it seems like the experts that were responding were pretty
Right.
divided on what should be included, what should be omitted. But then as they saw each other's responses after round two, started thinking about it a little bit different.
Absolutely. The composite scores that we present in this article really do well summarizing kind of overall thoughts on this. And so it does well summarizing, okay, even if 75% agreed with it, did the other 25% strongly disagree? And so you're absolutely correct. There was a lot of variability in the responses. And then, consensus measures, you're expecting that. That's why you have to have decent sample size. And, I think that that's important to realize is there's individuals that don't agree with some of these concepts that were on this study. And so I think the variability is normal. I do think the variability in orthopedic manual physical therapy, in my opinion, is there. But I think it's overestimated a bit. I think when you talk about these individuals and knowing the individuals that were involved in this study, these individuals were from very different programs. I mean, very, very, very different programs. We purposely picked a lot of the very biomechanical ones that used more of the Nordic models. We incorporated a lot of the patient response models. We tried to incorporate individuals from all these different schools of thought, and they aligned on a lot more than I actually thought they were going to. And I think even moving forward with some of the projects we're working on right now, we're seeing that. The schools of thought, they're different and they make you look at things through a different lens. But at the end of the day, a lot of them do align on their overall beliefs on some of this stuff.
Another idea that you mentioned that I, as a manual therapist, had gained through my education was the reasoning behind it. So it gave me a very solid understanding as to why I was making the decisions I was making and incorporating them with the patient. Can you speak a little bit more about the concept of complex reasoning and how you would tailor that to the evolution of orthopedic manual physical therapy?
I think the clinical reasoning is still there. Obviously, it's a huge component of physical therapy in general. But I think the lens that we're looking at through is a little bit different. And I would venture to say it's a little bit more complex because we still have to include that biomechanical stuff. That is absolutely still important for us to think about. But we have to think outside of that realm, right? We talked about the biopsychosocial model. You have to appreciate all three of those domains throughout that whole assessment process, throughout every single treatment process. And more importantly, that we have to understand the dynamic nature of those things. And this is one of the things that I think really makes clinical reasoning for physical therapists hard. We see a patient and we identify that this perhaps psychosocial thing might be influencing them that day. And so we provide a treatment, maybe a hands-on treatment, maybe not, right? Based on this presentation they have, based on all this stuff they have going on in their life. And then when we see them back next week, those factors may have changed. yes, the biomechanical stuff might have changed also. You might feel less tone, you might feel less guarding and some of those things, but have those psychosocial factors changed also, perhaps? So it's almost this constant reassessment, constant adaptation of what you're doing, why you're doing it. And that to me is the clinical reasoning process of our current model. And I think it's challenging, but I think it aligns really well with the way manual therapists have already been trained. Like you said, we're trained to pick up on these things. We're trained to utilize these things, and our brains are trained to constantly adapt based on the patient in front of us, based on how they're responding, based on these multitude of factors. And so I think we do really well in that advanced clinical reasoning conundrum with some of these patients.
Speaking of the biopsychosocial approach, you mentioned the variability between the experts from the pain science to the biomechanical perspectives. If I recall part of your history, that was your impetus to investigate this as part of your dissertation and then write it up then as a manuscript. Is that correct? And could you expand on it a little bit?
I live in both of these worlds. And it's interesting because I am involved in several pain groups. I'm a pain mentor within the VA. I'm involved in a couple of these different things with individuals that are very much down that pain neuroscience education rabbit hole, who look at some hands-on stuff as, well, why would you ever do that? Why would you put your hands on people? And then on the other side of things, I know individuals and I work with individuals on the other side of that are more of a, oh, well, that pain science talking to patients stuff is overrated. And so I've always kind of lived in both those worlds and understand the value in both of these things. And I think when you look at these things contributing to the pain experience, and you look at the things that we modulate with hands-on techniques or exercise or education, and they're all just these things that kind of live on a spectrum of things that are getting wound up or wound down. And Amy McDevitt did a beautiful paper talking about shared mechanisms. And it was really nice because it outlines the idea that a lot of the treatments we do are doing the same crap, right? Essentially, they're doing the same thing. They're stimulating the same changes. They're stimulating the same brain regions to do the same thing. And while we'd love to say, no, 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 that's because I provided this manipulation at this direction, and that's why this patient got better. Maybe there's a possibility of that, okay? But they also may have gotten better with some other stuff, right? We don't know. Now, we're years off from having a good understanding of this, but I think these worlds align really well. And I think a lot of my dissertation work was just trying to tie these things together so others see things through the light that I do, that these things aren't separate entities.
Along those lines, if we're talking about reframing ideas, what would you think about this suggestion that manual therapy really is the bridge between the passive and the active? It is a little bit of both. I lean towards the idea that it's more active than not, but there is a passive delivery of some aspect of it, right? So would you think that would be an okay way to frame that?
I think the first question you need to ask is, are you talking about manual therapy as a technique or manual therapy as a philosophy? Okay, because manual therapy techniques are things you can go to a weekend course, learn, and say, I learned how to press on this segment and do this thing. That itself in isolation is pretty passive, right? But the philosophy of manual therapy and what most schools of thought teach, right, is this idea of, okay, you're going to check these things, and then you're going to provide this technique, and then you're going to recheck these things, or you're going to see what you can improve and give them something to maintain it. So they all have a very active component to them when you look at it from the philosophy standpoint. So I think using that umbrella term manual therapy and saying, is it active or passive? It depends on which one you're talking about, because we bill manual therapy as a CPT code. And they're not looking at the philosophy. They're looking at if you provided a technique, right? But when you talk about orthopedic manual physical therapy, or even the philosophy of manual therapy, it looks at this very, very active treatment plan. And it looks at having the patient involved in that as an active member of that treatment plan when it comes to the person-centered approach behind it.
That's very well said. So it does seem like the priority out of your Delphi study, which I think led to a follow-up manuscript, is the patient-centered approach or the patient-centered factors. It's a great paper for several reasons, one of them being how you outline the historical manual therapy model and compare it to the person-centered manual therapy model, and then the description overall of the person-centered approach, which includes context. And Damian, that leads me to two questions. The first one, there's a statement in that manuscript that reads, recent trials demonstrate discrepancies between physical therapy perceived ability to provide person-centered approaches with the inclusion of the biopsychosocial model. Can you speak to a moment as to your thoughts as to how we can better adopt this person-centered model with the underlying themes of the biopsychosocial model?
Absolutely. And it was really interesting because, when you looked at the results, and again, I wasn't involved in writing up the themes for this. This was based on that open-ended questions to the individuals for this Delphi. And when you see the responses, they were all focusing a lot, and not all of them, but a lot of them were focusing on the patients, patient expectations, communication, therapeutic alliance, addressing lifestyle factors, all of these things that were very patient-centered. And so following up on this, I really realized that we understand where manual therapy, these individuals that are already training in these programs understand the person-centered nature of it, but it really hadn't at that point been presented in that light where you could say, oh, this is how manual therapy fits into this model. So it's actually a funny story behind that manuscript you just mentioned. Is Nathan Hudding was on that manuscript with me, and for anyone that doesn't know, he was recently elected as the IFOMT vice president. Wonderful person out of the Netherlands. But this really speaks to some of what social media can do. Is I live in Ohio, and I randomly saw Nathan Hudding post something about saying, "Hey, I'm presenting at the Ohio conference. Come see me." And I had absolutely no intention at the time of going to this conference. But right away, I reached out to a friend of mine, Ken Learman, who also lives in Ohio. And I said, Ken, we're taking a trip. We're going to go to Columbus, Ohio. We're going to go see Nathan talk. And so sure enough, we drove. We went to this Ohio State conference. And there's Nathan Hudding, this guy that's published a lot of the literature on patient-centered care, beautiful works. And he's standing there hanging out at this conference. So we ended up talking to him quite a bit. We had lunch with him, and then we ended up leaving the conference right after his talk, actually. But this really sparked the interest. I started talking to him about this, and I said, hey, we did this Delphi, and we found a lot of these people really focused on these person-centered aspects. When it comes to manual therapy, we should write a paper on this. And he said, absolutely, reach out to me. And sure enough, within a couple months, we went back and forth and developed this clinical commentary for JOSPT Open. And so it was a really nice way to tie several concepts together. Like you already mentioned, or like we already talked about, the biopsychosocial model, manual therapy, the different mechanisms contributing to pain and those different pain phenotypes that the IASP outlined. And it was a nice way to pull all those things together into a nice, very clinically relevant paper. And I really appreciate what JOSPT Open is doing, because this was an absolute pleasure to write this. Props to them over there for what they've done with this journal, because it was a lot of fun doing that paper.
That's so interesting. I often have to remind students and new graduates that the evidence-based model includes the patient's values and expectations, right? So it's just a little reminder of that biopsychosocial approach, which I'm a big fan of. However, what I've also recognized is that when people go to the Con Ed courses, they're looking for some kind of actionable technique. It's very hard to teach the biopsychosocial approaches and the abstract nature of that and to get that across. I don't think that those courses are as popular, or they're not as frequented as the ones that are offering techniques and the ones that are offering certifications and the ones that are offering these tangible expressions of physical therapy.
I get this question frequently related to, well, how do I actually incorporate this into it? And it's challenging because one of the major concepts for person-centered care is this idea that you incorporate the patients within the decision-making process. So this has a couple of challenges, because you can't just tell a patient, well, what do you want? I want a manipulation. Great, lay down, let's do it, right? There's a lot of other things that need to be incorporated into that decision-making process. And for me, I always tell people, you have to meet them halfway. Okay, you have to take the patient's expectations, their beliefs, what they've experienced in the past. You have to take your clinical exam and what the best available evidence says, which all I did there is just outline the 3 tiers of evidence-based practice, right? And you incorporate this into this discussion with the patient. And that, to me, is the addition to my clinical practice when I really incorporated these models that wasn't there. Because I was already, very patient-centered in my assessment and all of those things. But I think the big thing that I lacked until I truly dove into using these models was asking the patient, what do you think? here's what, the research said we should do. Here's what I think based on some of the stuff I'm seeing. Here's what I think might be some of the options we could pursue. What do you think you need? And it's amazing the things you hear. It's just opening that door for a conversation. Rather than being prescriptive, it's this idea of being more pragmatic in your approach.
That's why I'm such a believer in residencies and fellowship training.
We need to incorporate mentoring with this, which we know in fellowship education, right? We know the mentoring is what pulls it all together, right? You can get all these weekend didactic courseworks, but unless you have something to tie it together and individuals to help you apply that, you're not going to be able to do it. And so I agree 100% with that biopsychosocial model is we can sit here and say, okay, this is what it means. These are the things involved. But at the end of the day, people say, well, I just don't know how. And so we've established a mentoring program where we're following several PT and OT professionals throughout a year. And it's amazing the growth we see in these individuals when they hit that aha moment of, oh, this is what you're talking about. Oh, this is what you meant when you actually said that. And it really speaks to the importance of mentoring in postgraduate education to tie some of this information, some of these facts, some of this didactic coursework to actual clinic practice patterns.
Yeah, I would agree. And I just wish that we could get a little bit more momentum to the public and increase the public awareness. It's not until I sit with patients that they recognize that they'd never received anything like that, let alone even asking them what they think or how they feel about something or what they think they need. I have found that patients are often stunned when I ask them that, and they don't know how to respond because nobody in healthcare has ever asked them what they think they need.
Yeah, it's an interesting thing here. And it's amazing to see where PTs land on this spectrum related to pain and what our understanding is. And I truly think that we are leading healthcare professions.
Yeah, it would be nice to know how we can mobilize that so that more physical therapists felt like they were in tune with how you could include patient-centered approaches of a greater degree.
One of the big projects we have working right now that I'm really excited for is how do we teach this? How do you take these concepts, both from this Delphi study we did, as well as from this concept of person-centered care, and how do you make this standard for fellowship training? And so we have a study to develop competencies to transition orthopedic manual physical therapy fellowship training towards more of a competency-based education model. And I think it really helps us to outline what individuals need to be competent in and what the steps are to get them there. So I hope that that's going to come up with some pretty cool results.
Yeah, that's absolutely fascinating, and it's way overdue. And I imagine as a part of that would be if you're identifying the biopsychosocial and the contextual factors, that you are accepting them for where they're at, but you're working to modify that to some degree. Would you include that process as part of the manual therapy?
I think it depends on the patient in front of you. The whole concept of the person-centered care aspect is you have to adapt based on the patients in front of you. And so the example I always give to our orthopedic residents is I say, if I get a patient that comes in and is adamant and they say, all I need is ultrasound. Ultrasound has always helped in the past. And if perhaps whatever tissue I'm looking at, there's no evidence to support ultrasound's benefit there, I'm going to say, you know what? In this patient, I don't want to sit there and tell them ultrasound's not going to work. I don't want to nocebo the effects of this, but basically use the ultrasound, make them feel better. You just don't have to plug it in most cases. I don't want to lie to them, but at the same time, I don't want to take away something that's been beneficial to them. However, if you have somebody who has expectations and beliefs that are harmful, we want to modify those expectations and beliefs. So we do want to address those contextual factors. I think it's very much based on what their goals are, based on what the benefits and risks are of you trying to modify their beliefs, right? Because there are risks to that. Do you want to reframe and take away possibly the one thing that they believe in? And we've all had that patient that says, I just need my spine realigned. You pop the vertebrae back into place and I'm good for a year. And if we take that away, is that patient just going to be in pain? Is there going to be nothing that takes it away for a year? I don't know, but there's a risk with that.
Oh, once again, well said. I think that might be a good place to end. The idea that we are really managing the patient and using orthopedic manual physical therapy as a part of a multimodal approach that really integrates with the context of the patient and where they're at, and hopefully empower them to move better, function better, and take over their own healthcare and their own wellness. Is that a good summary?
Absolutely. It supports the idea that things have to change. and things adapt as new knowledge comes out. That's fine. That's the stuff I love reading.
Awesome. Well, thank you very much for all of your insight. It's clear that you are moving the needle, and the conversation we've had, all the thoughts that you've shared, I think are going to move some physical therapists in the right direction. It's been an absolute pleasure to talk with you.
Thank you. Thank you for having me. It was a pleasure.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.